Hello, my name is Doctor Roger Klein. I'm an orthopedic surgeon in Santa Rosa, California. And I'm here with Tara, my daughter, and I'd like to illustrate for you a casting technique which I believe is very useful for postoperative surgical patients needing ankle fracture care. The splinting technique is called an ultralight cast, and it's a hybrid between a cast and a splint. The benefit of it is that you have less pain in a more comfortable padded dressing, which will be less likely to give circumferential tightness on a postoperative patient where ankle swelling will be possibly enormous and where they'll have increased pain. This casting is a substitute for use of a bomb walker boot, which often does not give adequate special comfort or doesn't fit specifically to the particular patient, or to a coaptation splint that goes up the sides of the leg and possibly in combination with a posterior short leg splint. The use of fiberglass, orthoglass splints, or plaster splints which wrap in a coaptation style, possibly in combination with a posterior splint, can form a rigid sheetrock hard material which is very non-resilient and does not accommodate the swelling in the patient. As a result, your patients will have more pain, more need for postoperative pain medication, and possibly more complications with wound care and possibly longer hospitalizations. By using this particular splint, we can get our patients out of the hospital happier, quicker, and at lower cost. So it's got benefits to the treater, it's got benefits to the patient who's happier, and it also improves the outcome quality of your patient. So the idea is to put on a cast that's got lots of padding, like a Jones boot. Often we can't get simple cotton in the hospital, and these are sterile incisions. We may have an incision on the front of the ankle and on the side of the ankle, and what we want to do is use a combination of ABDs for padding. These are 5 by 9s, and then we use about 4 or 5 of the ABDs measuring 8 by 10 inches, and they're held in place with Acrylex roll. We'll also use some gauze, which will be placed on the sides of the ankle. So for example, we may have an incision on the side of the ankle and then the anteromedial aspect, and we start to hold it on with a Acrylex roll. We use the Acrylex because if we're using web roll alone, it would tear and wouldn't stay in place. This can be done in the surgical suite with your assistant, or the assistant himself can do it while you're possibly dictating the case and writing the orders. But this is the idea. We go around and catch the first ABD. It's applied very comfortably and smoothly around the ankle. And then we'll place a 5 by 9 on the front of the ankle joint and layer these as we go. Can you help me open these? On the second ABD, we're going to go underneath the foot and hold it in place and capture it with Acrylex. So these will overlap and cross in the back of the ankle. Then the more narrow one. If we don't have the 5 by 9s, you can also tear these along the glue line. These will tear very effectively, as you see there. And they will actually break in two, and they always tear in the right way. So we're going to pad quite a bit, and then we'll fold this back. So this is going to give us padding to the forefoot. We fold it back later because we can get pulses and check the circulation comfort of the foot. I will typically take this padding all the way up. I have overlapping pads in the dorsum of the ankle because this is where it's going to be most swollen. We'll put one at the top, and then one, in this particular case, put the smaller one in the front, and another one in the back. This gives uniform padding. At this point we're going to have warm water, which is good. Once the padding is held with Acrylex, we don't need to tape it, we'll just go with web roll. We have 4-inch web rolls. These don't need to be sterile because the dressing is so large. And if we feel like we're going to have increased issues with swelling in the back, we'll put an additional pad in the back. In this particular case, we have one more 4 by 8, so we're going to use it. And we'll put in a second one in the back here. This will give a little bit more accommodation for the swelling, and in a particular place where swelling is an issue, by having a little bit more padding, the patient will have much better comfort and control. Then we're wrapping the web roll over the Acrylex material because we're going to apply a cast, and if you apply the cast directly to the Acrylex material, it's not going to relax and release as it should. The wearable material is a fine cotton material that allows us to maintain good position of the fiberglass. So we have a circumferential wearable wrap on top of the Acrylics. Once all the areas are covered, we'll go ahead and fiberglass. This will be folded back later and shaped for the patient. Often with casting, stockinette is used. There's a tube stockinette, possibly all the way, or possibly at the upper end and the lower end. But we're not using this specifically, avoiding it on this particular cast because we want the fiberglass to open up. So next we're going to put on fiberglass. We'll use, in this case we're using Scotch cast 3-inch and 4-inch. We don't want it to be heavy because it's important that it be an ultralight material. It's going to form a very thin fiberglass or plastic shell. It's going to be conformed to the patient. It's going to hold the foot in a plantar grade position so that the foot's not inverted, it's not too dorsiflex, and it's not too plantar flexed. These casting materials are usually put on quickly and they're put on warm so that we can harden them up without delays. So in the operating room, we'll have an assistant holding the toes up. In this particular case, I'm going to have you bend your knee down. Put your foot right on the corner and come toward me just a slight amount. Good. So we're just going to hold it in this position. This can also be done in the office. But in the operating room, might have an assistant holding the foot in neutral position. So we're wrapping around the ankle to make sure that all areas are covered and there's no gap or break over the Achilles tendon. And there's sufficient strength underneath, so if any pressure is placed on it, the cast won't break down. Can you relax your heel a little bit? Just let it go down. And the rest of it's going to be very thin with 1 4-inch fiberglass. This is usually done before the patient is awakened in the operating room, or if they're under spinal before they are awakened up. The fiberglass is pushed off as it's rolled, and it sets very quickly. By using fiberglass, there's less likelihood of getting burns to the patient's skin, and it's going to be much better comfort than if you use a Bledsoe or Ron Walker boot. All areas are covered with about 2 layers of fiberglass, and that's all it takes to give it enough shape so that when we convert it to a splint, we have something that's going to form and fit well. So at this point, when we relax, in the operating room, we usually have lead aprons on. We keep our surgical covers over so we don't get fiberglass residues on our aprons, and we hold the foot in this position so that the forefoot is not inverted or everted, and we maintain position here with bimalleolar molding and make sure that the foot is 90 degrees to the axis of that tibia. This will harden in a minute or two, and then we're going to split it. And the key at this point is by splitting it, it will be released all the way down to the skin from this point up to the point above the fracture site so that there will be nothing circumferential whatsoever. I find that this takes very few extra minutes in the operating room, but the patients have much better pain control for ankle, calcaneus, talus fractures, and as a result they're much happier, their skin care is much better, and they're less likely to get skin necrosis or wound care problems. Once the fiberglass is starting to take a mold, we'll check it down here. Possibly rest it on in such a way that it won't dent. We'll just hold the foot flat, make sure that the bottom of the cast is flat until the fiberglass has taken a shape and hardened up. So using the cast saw is going to make a considerable amount of racket, so I'm going to explain ahead of time what we're going to do. We're going to take 2 splits down here. The splits aren't straight down the middle, but they actually widen as they go to the ankle joint, so that this is going to have more circumferential rigidity at the top end, and it's going to be more it's going to be looser down here at the ankle to better accommodate swelling. So the area moment of inertia is going to be similar up here as down here, where the thickness of the fiberglass is a little bit thicker. We want to release it a little bit more so it's more accommodating. How's that feel? So, we'll bring in the cast saw. This is a marking pin, so I'll typically mark it. My assistant's going to be releasing the cast. The cast is split and wrapped around anterior to the lateral malleolus. It comes down and opens it up to the side of the fifth toe because we don't want it to pinch at the toe. These points over here can cross, and that will give us a more relaxation and less rigidity. And then we make another separate cut here because as the swelling goes down, we might be able to close it up with an ACE wrap. So we've brought it over just anterior to the medial malleolus, and another split here that gives us a shoe high split over here. And we're ready to split the cast. At this point I'll take off the glove because the residue will get on the cast saw. So this can be taken off fairly quickly because there's so much padding it's not going to be burning or catching the patient's skin in any area. Once the fiberglass is released, it's removed. We cross-cut a little bit to make sure we don't have to struggle with it. And I find that it's very seldom ever needed to use a cast splitter at this point. This shows how flexible it is. At the top end it's very flexible. Down here, a little bit of flexibility but not too much. There's a little sample right here. You can see the part that's taken out is much thicker down in the ankle area than it is up above. And so we want to remove more tissue, more of the cast down here so that we have more flexibility. And yet, if we wrap this on with an ACE wrap, it's going to secure very snugly and it's going to work very effectively. At this point, I carry bandage scissors with me, and it's very important to finish by doing the release of the soft tissue padding. Even if we have an incision on the front of the ankle, we're going to release the webral and the curlex up above the ankle dorsal surface. At this point, we can lift up the ABD or even pull it out, and there'll be even less swelling than would have been, and more accommodation for swelling. So at this point, we have an ABD a little bit down below. I'll even release it at that area even more close to the incision. I release it to above the ankle fracture site, then I layer it back in. So the patient believes that this is circumferential and isn't about to take it off. Then at this point, we can reach in and check a pulse and make sure the foot's not too tight. If it's too tight and the nurse calls me in the middle of the night and they think the patient may have too much swelling, possibly compartment syndrome or something, I'll ask them to take off the ACE wrap and reapply it. At this point, we're going to apply an ACE wrap. Typically we could use a 6 or a 4. I have a 4 in my hands, it'll work fine because it doesn't have to go the full distance. We can also put another pad on here so that it's not too tight, and then the nurses can take that out later if it's a problem of comfort. So we wrap it once around the foot, once around the ankle, and it can be open in the back. It doesn't have to be uniformly aced the whole way. And we put a little bit of snug on here, and it's going to close it up and give it a good fit, and take it up to the top of the cast so that one ACE is going to do the whole job. At this point, we're done with the surgery, and we immediately put the leg up on two pillows so that the foot is above the knee and swelling control is immediately adjusted. Then at this point, if we need to as well, we can take out the last ABD and it's no longer quite so tight in the forefoot area. If the nurses have problems with tightness, we'll just simply release the bandage right here. How does that feel?
Great, really comfortable.
Feels good?
Yeah.
Okay. So now that the ACE wrap is on place, it holds it together, and yet it can accommodate the swelling at the top end, and most importantly down here where you may have major soft tissue injury from a fracture dislocation as well as from a surgical intervention at the ankle joint. This is called the ultralight fiberglass cast. It's used for post-operative purposes on the lower extremity. We also do the same sort of thing with the forearm for a patient with an open reduction of a volar plating on a Kleist fracture or a forearm fracture. And I use these splints as well in a long arm fashion for patients having supracondylar humerus fractures. Thank you very much. Okay.
Good.
Now?
Okay.